It is fascinating with the competing interest groups. Like, you don't have people outside of the American Academy of Pediatrics lobbying against orthopedic surgery,
No.
right? Same
Yeah,
level of
yeah.
evidence, same degree of consent, but we know it works, and it's all stigma.
Yeah. And there's even too, when I was like trying to learn a little bit more about parental consent and what's the, rules and regulations for other things and whatnot, like the American Academy of Pediatrics has a whole like huge document about informed consent and decision making is the title of it. There is no reference anywhere about including legal process to allow like a legal guardian to provide consent. It's assumed that that's what is the next step if a child doesn't have consent.
This makes me want to do a podcast episode on informed consent, guardianship, conservatorship, Britney Spears.
Yeah,
sure. So important.
Welcome to the Good.Enough.Shrink podcast. We are your hosts. I am Jenna Chang, a child, adolescent, and adult psychiatrist practicing here in Los Angeles, California.
And I'm Dr. Patrick Kelly. I am also a child, adolescent, and adult psychiatrist practicing in the Los Angeles area.
We are on a mission to demystify child psychiatry and have conversations surrounding difficult topics on youth and adult mental health, but not without a little play along the way.
Welcome back to the podcast. Today, we're continuing the conversation surrounding electroconvulsive therapy, but specifically focusing more on adolescents. We last talked about the safety and effectiveness of ECT. It's one of the most effective treatments for catatonia, mania, and depression, especially with psychosis.
So we're delighted to continue the conversation with special guest, Dr. Michael Couse, who's an attending psychiatrist, board certified in both general psychiatry and child and adolescent psychiatry, currently working at the Olive View UCLA Medical Center in the emergency room, focusing on emergency psychiatry, but also looking into expanding the treatments available for patients at that facility, including ECT. Dr. Couse, thank you so much for agreeing to talk to us and bring some life and concrete examples to this discussion.
Thank you so much for having me on. I'm really excited to talk about something that I'm very passionate about.
And I'd just like to add, I had the privilege of training alongside Dr. Couse over here at Harbor UCLA Medical Center. And these kids, their cases are very devastating. There's just so much hopelessness in the families. And so I really did see a lot of the passion in the way you worked. It was very much felt in the surrounding.
And for full disclosure, I also with Dr. Couse at Harbor UCLA Medical Center, and we'll get into the discussion when we talk about this particular case. But I believe, in a way, I was, to an extent, one of the barriers in getting ECT moving forward because I genuinely did not think it was possible. I had trained in a different state where ECT was more common, and the general knowledge in California was that ECT cannot be performed on adolescents. In fact, Dr. Couse and I reached out to a prominent psychiatrist in California who essentially said, I wish you the best of luck. I've been trying to do this for 30 years and I've never been able to accomplish it. But Dr. Couse was unperturbed. And so I think part of the discussion is not only why this treatment and how effective it can be, but that continual advocacy for our patients can really move things forward and change things that can seem at first to be unchangeable. So, Dr. Couse, if you'd like to tell us a little bit about the case and how it came about, I think that would be fantastic. I will say one caveat for the listeners, just so you know. This case was published in an academic journal, and as part of that, full consent to discuss this case without using names was obtained from the patient and from their family to discuss this case and to use it as an example of a highly effective treatment in a patient who was treatment resistant.
Okay, yeah. So just to give a little bit of background, I became interested in ECT in my child and adolescent fellowship, which is a little unusual, but it was largely based off of two cases that I saw that made me very passionate about it. And we'll be talking about one of these cases in more detail. But I think it was the realization of the difficulty of obtaining ECT that made me so passionate about it currently. And so to give a little synopsis of the case, the patient was a 15-year-old boy who had no previous medical history, no previous psychiatric history, but did have a diagnosis of autism, but was fairly high functioning in the sense that he was attending school, regular classes, with some accommodations at school. He had some maybe mild to moderate verbal communication deficits, but largely was fairly high functioning. And so when he came to the hospital, he was brought in by his mom, who said that for the last 2 months, there was a progressive worsening of classic catatonic symptoms, including a decreased mobility. By the time he came to the hospital, he was completely mute, interacting in a very limited fashion with his external environment. So when he presented, he was diagnosed with catatonia, and his score on the Bush-Francis catatonia rating scale, which is a commonly used rating scale to evaluate the severity of catatonia, was 17 at the time that he presented. Because of the fact that it wasn't sure what the cause of catatonia was. Catatonia can be associated with both medical and psychiatric conditions. A full medical workup was done, and this included an EEG, imaging studies, laboratory studies of the CSF, the cerebral spinal fluid, all of which came back negative. But because of the long period to have the result of some of these more kind of obscure studies that were done, he was empirically treated for autoimmune encephalitis, which sometimes can present with catatonia. And so he received both IVIG and IV steroids. However, there was no improvement following that. And then once all the studies were returned and everything was negative, it was determined that most likely this was not due to a medical cause and thus some sort of psychiatric reason for his catatonia. We then started trying to treat him a little bit more aggressively for the catatonia. And so we started treating him with the first line treatment for catatonia, which is lorazepam or Ativan. We then fairly quickly titrated the Ativan up to a total of 24 milligrams a day. And that resulted in a very mild improvement, if anything. And then we added kind of an augmentating agent, sometimes NMDA receptor antagonists like amantadine or memantine can be used in catatonia. So we added that, which also had a pretty minimal benefit. At that point, we were already starting to come to the understanding that pharmacological intervention was probably not going to be very effective. But once we titrated the amantadine up to maximum doses and there was, again, very little improvement, we then were looking for what other options we could try.
And just to be clear, Dr. Couse, I think it's important to mention that the patient was on an inpatient unit being monitored the whole time, that he had reached that level of dysfunction that he had to be kept in the hospital. So it may sound to people who are listening to this, 24 milligrams of Ativan, that's a month's supply. How would you give that all in a day? But Ativan does have a very specific indication for catatonia, not that it sort of relaxes anxiety and that helps somebody move a little bit better, that for catatonic symptoms, it's a very specific agent and needs to be used at very high doses under close monitoring. So this is someone that we were on top of, on a nursing unit, being monitored very closely during that time. And despite all these, what sound like very aggressive interventions, he wasn't responding or really getting any better.
No, and for someone responding to the benzodiazepine when they have catatonia in a hypoactive, some type of catatonia, you would expect them to become actually more active, become more engaged. And in the mild improvement that we did see from the Ativan, there was a little bit more of an interaction with his external environment. Again, he was largely unresponsive to anything, any stimuli. So there'd be a mild interaction, but again, he was still severely impaired and required assistance with everything, including, feeding.
And so, Dr. Couse, it sounds like this might have been around the time that the idea of ECT came forward. Could you talk a little bit about what that discussion was like, both amongst the team and why I told you it was not possible, and how you started moving that forward? And then when it came to that point, the discussion with other interested parties, including the patient and family, and maybe even the pediatricians.
Yeah, I think the frustrating aspect at first was you read about catatonia in any textbook or any guidelines on treatment, and it's very clear what the next step is, ECT. But then actually providing it was a complete unknown. So then we were fortuitous in the sense that at our hospital, there was already an ECT service that was provided to adults. So we had at least the kind of infrastructure for ECT to occur. But then it was trying to figure out what are all the legal regulations, which meant finding the actual law and reading the law, which was very boring and dry, but it had all different stipulations that needed to occur before ECT could in fact happen. But we had also the legal team there at Harbor was helpful in being in contact with the mental health court here in LA County, although it did take quite a bit of time. I guess speaking to the family, I was concerned of bringing that up until I knew that we could at least move forward with it, because I didn't really want to offer hope if I was then going to say, well, unfortunately can't give it. So his main family member, main support was his mom, and obviously had some concerns of ECT. It was mainly kind of like long-term brain damage was her main concern. So discussing that with her was important.
And to be clear, that discussion was that there's no evidence that there is long-term brain damage, correct?
Right. There's some studies showing kind of before and after, I think, of MOCAs that were done in adolescents and showing a minor improvement, which you would presume was probably because the disorder that they were experiencing is improved with ECT.
Just to clarify the MOCA you mentioned, MOCA is the Montreal Cognitive Assessment Test for cognitive impairment that we use all the time. So for people who have never heard of it. Yeah.
Great.
And I think another barrier in this case that's common with people with catatonia, but especially problematic in this age group just because of the court, was that the patient couldn't speak. He wasn't capable of speech at this point due to the extent of his catatonic symptoms. So all of his consent, or in this case assent, was implied. So the main decision maker really was his mother, with both the mother and our team interpreting his responses and his understanding of the procedure to begin with, which was, I think, one of the big reasons that the court got involved so deeply in a case like this, but is actually not that uncommon in adults because it's used on such sick patients.
Right. The California law, if we want to get into the various stipulations of the law and then maybe some of the interesting aspects of it. So for an adolescent between the ages of 12 to 15, for ECT to occur, it must be in an, quote, an emergent situation where convulsive treatment is deemed life-saving. And so that's determined by the court that it is life-saving. There then needs to be substituted consent must be obtained. And so the court would then need to determine that the individual doesn't have capacity and therefore then must give the ability to consent to family members, so, to the patient's mom. It also needs to include a letter from 3 board-certified child and adolescent psychiatrists, all unanimously saying that it is an emergency situation and that ECT is life-saving.
Just to paint this picture of like what's happening. So, Dr. Couse, you and other psychiatrists are meeting with a judge and explaining the clinical information, the necessities to this judge who has, essentially no clinical training to then make a decision. And this process, how long did it take for you?
I believe it was 81 days since presentation before we were able to perform ECT.
Mm-hmm.
So it took a long period of time. I would say probably by week 3, we had a good understanding that the medications were not going to be successful. Obviously, we weren't the most efficient in getting everything that we needed to present to the court, but I would also say that the requirements, if you can compare them to any other medical procedure, even if adolescent doesn't have the ability to consent, are vastly different than any other medical procedure. And so that, coupled with just the timing to have the ruling and everything, did take so long for us to eventually get that set up.
Yeah.
And Dr. Couse, I know we're getting a little left from the full case presentation, but I remember going through this, that was a very frustrating element of this whole process, that we had an evidence-based treatment, mountains of evidence behind it, a facility capable of performing it, a family who wanted this treatment, who thoroughly understood the risks and benefits, an adolescent who wanted this treatment, and yet we still had to argue before this third-party reviewer who had a lot of interest and experience in patients to an extent. It was the mental health course, but no formal medical training, about why we felt this was important, why the family agreed to it, and it gets sort of a declaration to move forward, which, I think 81 days was the total time, but I think we were going through that process for at least a month and a half once we all decided it was a good thing to do.
Yeah, I would say, yeah, I would agree. It took that long. I don't know if they maybe shared the same urgency that we may have had. In fact, our first court hearing was delayed a week because one of the lawyers, I believe, didn't receive the information of the case and therefore was not prepared. And their decision was to then just delay it a week, which was obviously frustrating.
And during this time, what are you seeing in the child clinically? What's happening?
I mean, sadly, he's immobile, requiring a staff member to feed him soft food. There were periods of times where there's some concern of his ability to in fact even swallow, but it didn't progress luckily to that extent. So he was able to swallow. He's posturing or in contracted positions for a long period of time, and difficult to even move him because of the rigidity. So extremely uncomfortable. It would be horrible to see your child like that, and obviously to experience would be horrible as well.
And to be a parent and be told your child is going to be like this for another week because of delays in court proceedings, a week is an eternity to watch your child like that.
Yeah. It was really sad to see her and see her son suffering so much.
And I think the good news is that you did achieve the impossible and persist and get the court to agree to substituted guardianship or substituted consent. I forget the exact term. And so you were able to move forward with the ECT. So tell us about that process.
Well, I will have one more gripe that I do have to mention, was that once we did get the approval to move forward with the ECT, there is also written consent that needs to be signed. And the consent by law needs to include the verbiage that there exists a division of opinion as to the efficacy of the proposed treatment, why and how it works, and its commonly known risks and side effects, which is not accurate. It actually hasn't changed since the original California welfare and institution statutes were put in place in the late 70s, and is clumped together with psychosurgery and insulin coma therapy. Which just, I think, goes to show how ill-informed the process overall is. Having said that, though, since things did eventually go our way.
Well, that is a very important point, I think. It leans towards a lot of the things that we're saying, that the legal statutes have not kept up with the evidence base and are not commensurate with what we now know about ECT. So they're basing all these discussions, a lot of these regulations, and a lot of the patient's protections on old, outdated data that no longer apply.
And just
Correct.
to hone in that point too, psychosurgery, insulin coma, these are archaic procedures that have been completely debunked. We do not even, this is one of those things that psychiatry as a field, we've made mistakes, terrible things happen to people, and yet we're continuing to try to find life-saving measures. And ECT truly is one that has persisted and continue to show over and over again that it's effective and safe.
And it harkens back also to the history a little bit of the laws themselves. They were largely put in place during the anti-psychiatry movement, which was pretty big in California in the 70s and 80s. And I think ECT, because of its imagery and stigma surrounding it, was probably something to focus on for these groups, and they were able to pass some legislation.
Yeah, that's one of the things that really shocked me when I moved out here for training in child fellowship, because my adult training was in Pennsylvania. ECT was so common. You really just needed parental consent and one other psychiatrist to get it approved, for minors. And so it was quite shocking to me. And I think inevitably we will reference the One Flew Over the Cuckoo's Nest, the book, and the subsequent film with Jack Nicholson, I believe. That just, it created this impression of ECT, again, very, very different from how we do it today. But I think this is why we want to talk about this in this podcast, that we are real psychiatrists, real humans, believing in this procedure, really seeing firsthand how it saves people's lives. And yes, it's a really serious decision. It's a difficult decision. But to make it so difficult to obtain, it is, you have to question the ethics of that, how much time and energy and mental suffering people have to go through to really obtain a life-saving procedure.
So tell us about your patient. Did it save his life?
It certainly helped him significantly. He had a robust response. By the time he was discharged, I should say, he received 11 sessions of ECT. How they're normally administered is like a Monday, Wednesday, Friday kind of schedule. So he received it over a period of 4 weeks. He received the 11 ECT sessions. By the time he was ready for discharge from the hospital, his push Francis catatonia rating scale was 1. He was speaking in full sentences. He was walking on his own. He was able to complete all of his activities of daily living independently. I think Dr. Kelly and I saw his personality come out a little bit. He was a bit of a prankster at the end there and was having fun with the staff. So it was a really beautiful thing to see just how much he kind of regained his life.
I call that life-saving.
Yeah, when you get a child to be playful again, that's true sign of progress.
And so, Dr. Couse, I think thinking more broadly about this, what are your thoughts about everything you went through and the idea of how maybe we can try to move things forward? I mean, I think from a global sense, if we have an evidence-based effective treatment, I understand that people talk about patient protection, but I also think there's an idea of denying treatment to patients. And, I think some of the more vulnerable patients who don't have the resources to fly to another state where ECT is more available, or to hire a lawyer to fight the courts, or necessarily even pay private or pay for treatment in a different location. This may be an access issue.
It's most definitely an access issue, and there are multiple factors at play for why the access is so poor. I think especially kind of the Western United States, it's probably at its worst. But overall, there was a study that was looking at the use of ECT in hospitals throughout the United States. And regardless of what region you're in, there is a decreasing percent of hospitals that offer it, most notably in the Western United States. About 6% of hospitals offer ECT. So it's a very low percentage. So trying to increase facilities that offer it would obviously be very helpful. I think the knowledge base of either pediatricians, child and adolescent psychiatrists, or psychiatrists overall, in their understanding of ECT and maybe to the full extent of just how effective it is and how limited the adverse effects are, I think is important.
I was interested in that as well, because we sort of jokingly talked about that when you brought up this idea, myself and other very seasoned psychiatrists said, don't even bother. Essentially, in California, you can't do it. And so we were lucky, frankly, and the patient was lucky to have someone like yourself who was so dedicated to pursuing this. But in addition to the legal barriers we're talking about, I think there are barriers even in our own field where the people who are supposed to be training the next generation of child psychiatrists themselves are either not aware or not comfortable with the idea of ECT in this population, and there are geographic differences around that. Do you have thoughts about that? Either ways that we as a field could expand our knowledge and awareness of this as a potential treatment in our population, and I'm speaking specifically about child and adolescent psychiatry, or at a advocacy level or a state or even federal level, how to potentially reduce barriers and increase accessibility to something like this?
Yeah, I think maybe a focus could be more so on at least ECT for catatonia, for maybe other disorders, depression, psychosis, for it to be determined treatment resistant while they're still a youth. That may not be as frequently seen or may not be as necessary, but catatonia is something where there's such few options for treatment, in addition to kind of a neurodevelopmental disorder in autism, which does have a high rate of catatonia, and there can be this progression to such a serious effect in their functionality that I do wonder if focusing more so on the treatment of ECT and catatonia could maybe loosen some of the restrictions and increase overall acceptance or desire to provide that treatment, because it is such a debilitating disorder, catatonia. Obviously, if there's any way for advocacy groups to try to loosen some of the restrictions of the state laws, that would be wonderful. And for it to not have to occur only when it's life-saving, I think could go a long way. Sadly, in the case that we discuss, the catatonia did start to slowly return over a course of, I would say, about a year, to the point where it's now we're a couple years removed. I believe it's not to the extent it was at when he presented to Harbor, but it has returned to definitely limit his functionality. And I would expect there to be a bigger hurdle for it to be approved for him now. And that's unfortunate because maintenance ECT is a well-established treatment.
To be clear for our listeners, so this would all have to happen all over again. It's not that once the court decides this for a given individual that ECT is a good idea, that persists. And so if he would have to go back, you're starting at zero. Is that correct?
Yes.
Yep. I love the idea of advocacy. The idea of spreading information can start from all the stakeholders who are invested or interested in this. So whether you're a patient or a family member, there are advocacy organizations that are dedicated towards that group of individuals. NAMI is probably the most well-known and the most famous one. NAMI California does have some advocacy efforts and access to treatment where this would certainly fit. If you're a psychiatrist, especially a child psychiatrist listening to this, Southern California Psychiatric Society and Southern California Society of Child and Adolescent Psychiatry also has advocacy efforts. That's in the local level. There are also state level organizations that are pursuing this. And I think there's a time lapse to it. Advocacy always takes time because fundamentally we're talking to the big decision makers and the big legislators. We're not making those decisions ourselves. But the more talk about this there is, and the more voices are out there, and the more information is being spread, I think the more people can learn for themselves how useful of a treatment this is. I remember at the most recent American Academy of Child and Adolescent Psychiatry national meeting, whereas in previous years there was maybe one or no discussions of ECT in this population, there were 21 posters or presentations just focused on the use of ECT for this population. So I think even in our field, there's increasing recognition, but there continue to be barriers in the way, and there continue to be difficulties obtaining this for our patients who are suffering, which I think is a downside and a frustrating experience to go through as a provider.
Absolutely. And Dr. Kelly, what you're saying about the hesitancy within our field, it also reminds me of within our training, I don't know that we specifically have a requirement to understand ECT. We have requirements to understand developmental kind of perspectives and addiction and forensics within our training, but procedural psychiatry, there's not like a dedicated curriculum to really understand ECT. And I also wonder, because it's so different by state, it brings in ethics a lot. It brings in informed consent, which can be a little dicey. And so it's a really complicated topic that I think us as psychiatrists are a little bit maybe resistant with. And so to present a case, the paper that you guys published, it really brings light to this problem.
And that's one of the reasons we were so excited to be able to sit down with Dr. Couse, a true expert in this from the ground up, someone who, filed papers with the court to move this forward and really understands the nitty-gritty of it. So, Dr. Couse, thank you so much for sitting down with us. Any other thoughts? Anything else that you think is notable or important to share with the people who are listening?
Well, thank you for having me. It was really fun to talk. I guess the last thing is just when you are in training, obviously your time that you have is a little limited, but you do have some flexibility to maybe do something a little out of the box or explore your interests or passions. And so I just say for everyone that is in training to go forward with that, because it can produce something very, very nice, like it has for me.
I think it's a wrap. That's really great.
Well, thank you. That was fun.
Yeah. It's so fun. It kind of keeps your mind active. It reminds you of all the things that you used to love, brings it back. So, yeah.
Totally.